Welcome to the show, Talk with Your Doc. I'm Dr. Prashant Jani, and our guest for today is Dr. Walid Shahrour. He is a neurosurgeon here at Thunder Bay Regional Health Science Centre in Thunder Bay, Ontario. He is Associate Professor at Northern Ontario School of Medicine, and he is lead of oncologic surgery in Northwestern Ontario. Thank you, Dr. Shahrour, for coming and being part of the show.
Thank you for having me.
I know you're so busy with so many patients and so many meetings and conferences coming up, but still you made a time and come here. Really appreciate it.
It's always a pleasure, and we always like to chat, and I think this is very beneficial for our patients.
Thank you.
And for the people, and I think it's a good cause, so I'm very happy to be here.
Thank you. So today we are going to talk a very important topic, which is kidney cancer or tumors of kidney. Now, about 500,000 patients every year worldwide are affected with the kidney tumor or kidney cancer. And the prognosis of kidney cancer is variable depending on the stage and what sort of treatment options available at that particular time. So Dr. Shahrour is going to talk to us all about kidney cancer. So Dr. Shahrour, please tell us how many kidney cancer surgeries you do every year.
I do around maybe 25 to 35 cases per year, but that's only me because I'm doing the laparoscopic part. I have my colleagues. We probably do around 70 to 80, like a total of 70 to 80 cases per year in Thunder Bay Regional.
And how many patients are diagnosed with kidney cancer or renal tumors every year at our center?
At our center, we diagnose around 100. This is the number of patients per year. Not all of these patients are going to go for surgeries per se. But this would be the average number per year of cases that we get.
So out of those 100 patients, about 80 patients undergo surgery, as you mentioned?
I would say around 70 to 80 would
80
undergo
patients.
surgeries, with different types of surgeries. And then some of them would be for watchful, like to watch, not to do anything. And some of them would go for some local treatments.
So after the removal of the kidney or a part of the kidney, you remove like total nephrectomy, which is complete removal, or you might be to partial nephrectomy. How is the outcome of those patients with the renal cancer?
In general, as you know, the earlier we diagnose things, the better, and the
Yes.
better the outcomes. So with kidney cancer, it's the same rule. In general, the outcomes are usually favorable. Sometimes we get patients in very early stages, and most of the time right now, because of the advancement in the diagnostic imaging, CT scans and MRIs and ultrasounds, we're able to detect things earlier. And most of the time it's actually incidental. It's very different than like right now compared to the past, where in the past patients used to come in at a very late stage and everything has spread. Right now we detect them way earlier than before. So for sure, the earlier you are, the better it is. And the prognosis in general is favorable in those kind of situations.
So to get it early diagnosed, what sort of symptoms or signs one should observe that, okay, he may or she may not have a kidney cancer?
Patients, they might have blood in the urine, feeling unwell, anemia, pain, but these are very non-specific.
Non-specific.
So that's one of the reasons in the past we used to have all these cases diagnosed at a later stage because we're not doing a lot of imaging. But right now we do a lot of imaging, again, as like the CT scans and MRIs and ultrasounds, that we detect them early. So usually patients will tell you, like, I'm not feeling anything, doc. I'm feeling fine. How come I'm having something like this?
Oh, so one can have a whole renal cancer and maybe completely normal.
Completely asymptomatic.
Oh.
And then, or one time they would feel some pain or some blood, and then now we do the imaging and we find it out.
So at what age does this cancer start? Like a young age, middle age,
I
old
have
age?
seen it at all the ages.
Oh.
It happens more as we get older, for sure. But I have seen it in younger, like I have seen it in teenagers. I've seen it with children. It's different kind of pathology, but I've seen it in all different ages.
So renal cancer can affect at any time to anyone at any age.
For sure. But we know it goes higher, like the risk is higher as we get older, similar to if you're a smoker, for example, it is one of the risk factors. Obesity is one of the risk factors. Patients who have high blood pressure that is not properly treated, it increases the risk slightly. Patients who are on dialysis or renal or their kidneys are not working well, they have also a risk like that. And for sure, we have the genetic or the family history.
What is genetic? Is there any sort of a test, genetic test available, or what are the mutations? Can you
So
tell us
there are
something about
certain
that?
mutations that we have. I don't want to be too technical,
Yeah.
but there are certain something called VHL and stuff like that that can happen, and then the patients would be at higher risk of kidney cancers. So this is one thing, and then the family history is another thing. So this might be in families, or it might be your own genetic mutation.
So if you have a family history of kidney cancer, then you may develop it.
You have a higher risk of developing kidney cancer.
So you should screen it and get monitored.
It is very hard to, till now, we don't have a recommendation by the guidelines to screen if you have a family member that had kidney cancer.
Okay.
But we are actually doing research right now to look into this. So we are actually, even here in Northern Ontario, we received a grant and we're doing research to check if there's any effect from the family history, and if there's any way we can actually recommend screening guidelines for patients.
Okay. So I want to know about different type of kidney cancers, and their prognosis is different. So how do you know which is a good type of renal tumor, kidney tumor, and which is a bad type? And can you please enlighten us something about that?
So I always say to my patients, kidney cancers can be a cancer in the meat of the kidney, or in the tubing or the lining of the kidney, or something from outside.
Okay.
This way, we can kind of understand the differences. If it's from outside, then it is coming from a cancer from somewhere else that has latched onto the kidney. If it's in the meat of the kidney, then it's the usual type, which we call renal cell carcinoma. And if it's in the tubing or the lining of the kidney, it is usually transitional cell carcinoma. And the different types would actually have different outcomes. Usually, the tumor in the lining of the kidney is a little bit more aggressive than the tumors which are in the meat of the kidney. But again, this can completely differ if this one is coming at an early stage and this one is coming at a later stage, or it has an aggressive type. And then once you see this general types, then you have the subtypes from the inside. So if you have the tumor that is in the meat of the kidney, but it is an aggressive subtype, then the prognosis would be worse than a less aggressive type. And then we have the tumors which are from outside, and these ones are, usually it is a later stage because they're cancers from somewhere else.
Thank you, Dr. Shahrour. We'll take a short break and we'll come back again. Please come back for the next part after the short break. Thank you so much. Welcome back to the show, Talk with Your Doc. Our guest for today is Dr. Walid Shahrour, and he's a Uro-surgeon at Thunder Bay Regional Health Science Center. We are talking about renal cancer. Dr. Shahrour, you were talking about different types of renal cancers, and some of them are not so good, like they're aggressive, some are good type. So all of them present similarly, like asymptomatic, or aggressive have more symptoms than the benign looking ones?
Usually aggressive ones would be growing so fast and faster than the non-aggressive ones. So maybe you might have a slightly higher chance of developing, for example, blood in the urine, where you can see that. But most of the time, it is detected incidentally on imaging.
Wow. So if somebody does not notice any change in their behavior and he's coming for some other investigation, and he gets, like I say, ultrasound of the kidney, and he finds there's a tumor. So what happens next then?
Well, it all depends on what we can see on the ultrasound. Usually we want to do a CT scan to check on the tumor, and if we have a very good idea, then we offer the patient a biopsy. A biopsy can be done, which is very simple. Easier said than done, but we go under the CT scan, and the radiologist would put a small needle from the side, and they take a piece from the tumor, and then we send it for the pathologist.
Yes.
And the pathologist gives us the news, what kind of tumor, and like, you know, usually the type is the main thing that actually lets us make the decision.
Yeah. Is there any blood investigations one has to do?
We do some like to check a general blood, like we do a blood panel to check the kidney function. We check the hemoglobin. We also check sometimes the calcium and the inflammatory markers. These are the basic investigations which we do. Sometimes if we find that the cancer looks very aggressive and we want to be assured that there's not anywhere else, we do a scan of the lungs. And sometimes we also do bone scans if we have suspicion that this cancer might have gone outside. Bone scans for kidney cancers are not very sensitive because the type of cancer does not really show very well on bone scans. So it is not always done, but the CT scan of the abdomen is for sure. And we also, if we are having suspicion, we add a chest X-ray or a CT scan of the chest.
Okay, so ultrasound, then CT scan, and then biopsy is required, and then after the biopsy, then depending upon the results, then you will scan for the bone metastasis probably.
If we're having suspicion from the size of the tumor or anything that shows abnormally on the chest X-ray, then we want to check if it has gone outside. We don't always even do biopsies.
Right.
Some patients, they don't want to do biopsies, and we basically go ahead with the surgery or the options that we can offer the patients. Nowadays, since biopsies are readily available, it is a good option to have. And I would say for sure that, you know what, we're almost good at detecting the kidney cancer from the imaging alone, but we have been surprised sometimes.
Yes.
You know, you go and you remove a tumor or you remove a kidney and it comes out as a benign tumor. So not all the cancer or not all the tumors of the kidney are cancerous. So there are some that are very obvious on the scans, and some of them that they can be in between. And this is why I think a biopsy is a very valid option to do.
Yes. So then what happens next? Like patient undergoes surgery, is that the option? Or is there any other treatment option like any medicine? If somebody doesn't want to do surgery, then?
We have a lot of options, and we're very fortunate here in Thunder Bay. So if you have a tumor, depending on the size and the appearance and the location and the patient preference and values, we put all of these things together in our discussion. So for smaller tumors, we can offer active surveillance, which means we're just watching the tumor and we see how if it is small, we can keep watching it and not do anything at all about it.
So just watch it and let the patient follow up after.
We just follow up with the scans and so on. This is usually for patients who are not medically fit, or patients who do not want to have surgeries, or patients who have certain medical comorbidities that would not allow them to go for anything.
Correct.
Sometimes patients, even though they are fit, they just do not want to have surgeries at all.
Yeah.
We have to respect their wishes and their views, and we offer it. But this is only for smaller cancers, usually less than 3 centimeters. Once you start seeing that this tumor or this cancer is growing and becoming larger in size, or you can see that there are features which are aggressive, or the biopsy is showing an aggressive type, then the options can be surgical. And from the surgery, you can do a nephrectomy, which is removing of the whole kidney, or a partial nephrectomy or kidney sparing, which is just removing the tumor alone. The other option from intervention is away from surgery, which is basically what we call focal therapy. And focal therapy is by inserting either a needle to freeze or a needle to burn.
Burn the tumor.
Burn the tumor. Now we are from all these treatments, we offer active surveillance for sure. We offer nephrectomy, and the removal of the kidney can be done via an open approach, cutting and going inside and removing the kidney and then closing, or laparoscopic approach, which is done through keyhole openings in the abdomen, and then in the end remove the kidney through a smaller incision. Partial nephrectomy can also be done via an open approach or laparoscopic approach. We hope in the future we're going to be bringing a robot in Thunder Bay. It's a very expensive tool to use, but it's an amazing tool. It helps us to do more of the partial surgeries because of the capacity of the robot. It's done by the surgeon still, but the
the remote
ergonomics are better and better than laparoscopy. But it's quite expensive. But patients are quite generous and they're donating for the foundation, and we're hoping in the future we're going to be able to get something like that for Thunder Bay Regional. And the third, like as I said, like the focal therapy, we are very fortunate. Dr. Rosenberg from radiology, we work together, him like and us, and we now started doing radiofrequency ablation. Now it's our second year, where we are putting the needles to burn the tumors, and we're actually working on even doing the freezing, which is the cryoablation in the future as well.
So let's go over each of the options in a little bit more detail.
Yes.
So you mentioned about open nephrectomy. So what are the advantages and disadvantages of this procedure, like opening the bigger incision?
It's a bigger incision, which means more pain, more like longer length of stay in the hospital. Usually patients will stay between 3 to 4 days. The advantages is that your hands are there.
Okay.
So it is technically easier than laparoscopic surgery.
Okay.
Now, another advantage is that if you have a huge tumor, it's also helpful to do it via open approach. But if you're a laparoscopic surgeon who's experienced, you can do the big tumors. So I do humongous tumors laparoscopically. It is not a problem at all. But still, the open surgery is always an available, like a possible option for us. The laparoscopic surgery for removing the kidney, the patients, they go home the next day.
Okay, it's a shorter stay.
Shorter stay, faster return to work, faster return to activities, smaller, the incision is smaller and is not as painful. So usually patients can get back to their normal activities within 4 weeks or 4 to 6 weeks. They feel like, okay, they're ready to work again and do their stuff again.
We'll take a short break and we'll come back for the next discussion. We'll talk more about the treatment options because I think this is where we will have to talk more and learn more from you.
Perfect.
Please stay back and we'll talk about more treatment options just after the short break. Thank you. Welcome back to the show, Talk with Your Doc. Our guest for today is Dr. Walid Shahrour, Uro Surgeon at Thunder Bay Regional Health Science Center. Dr. Shahrour, you were talking about treatment options, and we talked about different surgeries, partial nephrectomy, which can be done open, or laparoscopic, as well as complete nephrectomy or total nephrectomy, which can be done by the same, by laparoscopic or open surgery. What are the other treatment options available other than the surgeries for the patients?
So we have the burning or the radiofrequency ablation.
Burning and
freezing.
Freezing.
So these are the two types.
So what is burning, what is freezing, and who is eligible for these options?
So the burning is basically we put a needle and the patient is not under anesthesia, it's just under local anesthetic. So it's good for patients who cannot go under anesthesia. And we put a needle inside, and this is done by the interventional radiologist, and the CT scan is being done at the same time, and we burn the tumor.
So you put something through the needle, some chemical through the needle?
No, just basically it's an ablation with radiofrequency. It heats it up. The needle, the end of the needle gets heated up, and it has a certain distance or certain diameter, and it burns this area.
So needle goes into the tumor, you put some heat rays, and it burns the whole tumor.
Exactly.
And how effective is this treatment?
It is quite effective. It has been used for the past 15 to 20 years. So actually it has quite a bit of a follow-up for it. It is limited with the size.
So smaller tumor can only be treated by this option, whether it is a benign or malignant. Any tumor?
Usually we try to gear it towards the malignant because of the funding from the government is only for the malignant tumors. And it is basically, usually we try to go for tumors that are 3 centimeters or less, so that we can do it properly.
And what are the chances that the tumor will come back after burning?
Well, usually we have it between 3 to 5% that it can come back, but it is also very similar to other other treatment options.
So this burning option is available if you cannot take anesthesia of the surgery, or if you have some medical fitness and you are not fit for the surgery,
Or if you want it.
if you want it.
Some patients, they say, you know what, I do not want anybody cutting me.
Oh.
We respect that, and this is an option. And it is an option that's given from the get-go to the patients with these kind of tumors.
And you said another option is freezing. So can you please explain what is freezing?
Freezing is basically the same idea. We put certain needles in, and they have, these needles are special needles where we can put actually, we can freeze the tip. And the tip gets frozen, and with the tumor cells get frozen, and from the freezing they die.
So you pass certain chemicals, and then the tumor is frozen, no blood supply probably to the tumor, and the tumor is dead then.
Exactly, because kidney cancers are generally hungry for blood. That's one of the things that we always noticed, and from research, and this is how we based our medical treatments, but not for the localized cancer. We based it on the blood supply. So we put the freezing, it shuts off everything, and the tumor basically dies and sloughs off. The beauty about this option is that we can do it for a little bit larger tumors compared to the burning option.
Okay. So out of burning and freezing, which one is the choice if one has to select? Which is the better option?
In Thunder Bay region, we only have the burning till now.
Okay.
We're hoping we're going to get the freezing. The freezing would be a more versatile option because we can go for
Bigger tumors. So out of the surgery, open surgery or laparoscopic surgery, freezing and burning, there are 4 options now, and a patient can choose whatever, and the prognosis is similar for all the options probably?
Yes, the prognosis is very similar. We have, if we have the capacity to do partial, we always encourage doing partial so that we can spare the kidney and you can continue to have the rest of the kidney working for you. Now, if you're a patient who gets super, super stressed about possibilities of recurrences of the cancer, then it might be an nephrectomy.
Surgery is a better option.
Yeah.
And after the surgery or freezing or burning options, does the patient have to take any chemotherapy or radiation for the kidney cancer?
Usually for kidney cancers, we don't have chemotherapy. Now, if we're going to be talking about options, now there is a newer option that came out in the last few years, but it is only available in specific centers, which is radiation therapy, specific for kidney, that can be done for kidney cancers. The only catch is it is not always available. It's not available here in Thunder Bay, and we still need more longer-term follow-ups. But there are actually very good, promising data, and some kind of, I would say, midterm data. I would say that it needs further look into it.
So that's an upcoming option for.
This is an upcoming option, and definitely has a very big following, for it. People are excited about it.
Perfect. Now, is there any new research, clinical trials you're doing in the renal cancer at this time, kidney cancer?
We are doing research for all of Northwestern Ontario, trying to collect all the data for patients who are presenting with kidney cancers, trying to figure out if we can see certain patterns, and to try to see if there are areas which have lack of access where we can help, or to kind of target the resources to help those areas further, similar to our research that we did in prostate cancer. So we are always actively doing research in kidney cancers and prostate cancer. It's just, it takes time, it takes perseverance, but hopefully we can use this research to help our patients and our region.
So after the patient is treated, he got surgery or freezing or burning, is there any follow-up required for these patients?
For sure. The follow-up would depend on the size of the tumor, the pathology that we get, the general, if the cancer has spread outside or not. We do scans usually, and depending on your stage, the scans can be every 6 months or every 2 years. So we do CT scans, we do blood tests, and chest x-rays.
Any lifestyle modification required after the surgery?
I think in general you need to eat healthy. You need to be careful if you had a nephrectomy or a partial nephrectomy. You want to preserve the kidney function as much as you can. So decreasing your salt, eating healthy diet,
smoking,
quit smoking, losing weight, control of blood pressure. These are all important things that you should be following post post-treatment for kidney cancer.
Perfect. Thank you, Dr. Shahrour, for coming and guiding us on this very important topic
Thank you.
of kidney cancer.
Thank you so much. It was a pleasure.
Thank you, everyone, for being part of the show.